Okay. Hello, everyone. It's a pleasure to have another lecture, and it's a pleasure to have Dr. Elkadi as one of our featured guests to present his work. Before the introduction of Dr. Elkadi, I would remind you to please mute and turn off your videos. Questions will be at the end of the lecture. And yes, Dr. Shahata, we will have as much time as we can to accommodate the delay. We're sorry for the delay, but we managed to have it going. The lecture is going to be recorded, and we have been sending emails to the different members of the society to join committees and to have ideas. And we appreciate the people that responded and appreciate more the ideas and would like to create really a good enough opportunity for all of us to make sure that we're going to have a better service to all of us. Now to the introduction of Dr. Elkadi. Dr. Osama Elkadi is an associate professor of pathology at the University of South Alabama College of Medicine. He is also the Residency Program Director and a pathologist with USA Physicians Group. He is a graduate of the Cairo University in Egypt. He completed his residency in Albany Medical Center in Albany, New York, then moved to the West Coast in Oregon, where he did his neuropath fellowship, but he didn't finish. After that, he did his cytology fellowship at Hahnemann, so he zigzagged back and forth all over the country, and he's currently at Alabama and enjoying his career there for 8 years so far. He is a member of the United States and Canadian Academy of Pathology, the American Society of Cytopathology, CAP, and the American Association of Neuropathologists. The topic of his lecture is Selected Cases in Pediatric Neuropathology. Dr. Elkadi, thank you, and we look forward to hear from you, enjoying learning about neuropathology.
Thank you so much, Dr. Tawfiq, for the nice introduction, and thanks everybody for joining. I apologize for the technical difficulties we had in the morning before we start, so I really appreciate the opportunity to be here and be a guest speaker for today. So let's just start so we can compensate for the delay time. Would you please make the Dr. Tawfiq, can you hit the button to make the screen more full screen?
Oh, okay, let's see if that's going. Did we lose the screen or it is showing?
It's showing good. It's showing very well. Thank you so much. So the lecture today, the outline of today's lecture is going to be showing cases, try to make it as practical as possible, with focusing on the differential diagnosis by the location and radiologic features of each, because that's going to be a very important diagnostic tool, knowing the location and knowing the radiologic features of brain tumors. Of course, I will be using the 2021 WHO classification of tumors book, and then we will touch briefly on the molecular characterization, depends on the cases. So next slide, please. So let's start with having an introduction on the radiology basics, because as I mentioned, location and radiologic features of brain tumors, they help and make the formulation, help making a differential diagnosis. You really need to know your radiology, at least the basics, One of the most important criteria is, are we dealing with an infiltrating, ill-defined tumor, like, for example, astrocytoma, oligodendroglioma, or lymphoma, or is the tumor non-infiltrating, well-circumscribed mass? The differential is going to be totally different, and this piece of information by itself can help when you are dealing with a frozen on a brain tumor. If they're telling me it's an infiltrating mass, my differential diagnosis immediately goes into other areas than well circumscribed. So let's look at the next slide to show some of the features that we're talking about. So the first thing we need to know about brain tumors: are we dealing with an intraaxial inside the parenchyma of the brain itself, or is it an extraaxial mass? Intraaxial lesions you will have in differential of primary glial tumor, gliomas with all their subclassifications. Non-glial neoplasm, metastasis, abscess. The list is big. Extraaxial, you think about the meningiomas and the soft tissue tumors. One important feature is the rim enhancing mass has a list of also entities. Whenever you see enhancement, so the presence of enhancement on an MRI is an important feature, and it tells you this is a high-grade lesion. So knowing that the tumor is enhancing, and for example, you get called for a biopsy, and what you see on the frozen is low-grade lesion, then you should consider asking the surgeon to get you another sample, because the presence of enhancement indicates high grade. And so we have to correlate between what you see intraoperatively and the radiologic features, because that's gonna save you, and it has saved me several times, rather than calling it on the frozen low grade, and then the surgeon will be like, that doesn't make any sense, it's an enhancing mass. So that the diagnosis of a rim enhancing masses is high-grade gliomas and metastasis. One pitfall is the infarct, and some infections can also appear as enhancing lesions. The last radiologic features that's pertinent to the pediatric population is this appearance of cyst with enhancing mural nodule. That does not necessarily indicate high grade. So this is a very specific pattern, very specific imaging pattern that is usually associated with pilocytic astrocytoma and gangliogliomas, mostly low-grade lesions. So that would be one of the exceptions of having a lesion with a cyst and having enhancing, but not necessarily high-grade. The reason behind that is a lot of these tumors tend to be vascular, and vascularity or increased vascularity tend to cause enhancement on the MRI T1 images. So that's just a brief overview of the radiology, and we're going to be using this as we go through the cases. So next slide, please. Smear preparation, intraoperative interpretation, and frozen section for neuro can be very challenging. It can be tricky, the tissue might not be enough. So I always have to do a smear preparation. Smear tend to have to give you more information actually than the frozen. They are quick and easy to perform, and certain situations when the tissue is very small or the markedly heavily cauterized, frozen is going to be very challenging. Plus, there is a freezing artifact and the fixation artifacts that comes with the frozen. And it's even superior than frozen sections when you want to see the cytologic details, you want to see the background, the fibrillary background. All this is better appreciated during the smear preparation. It's going to be very challenging on the frozen section to actually know what type of tumor it is. You might be able to tell high grade, low grade. You're going to see necrosis, you're going to see areas that looks high grade on the frozen section, but on the smear, to be able to tell what type of tumor it is probably better. That's been my experience, and I know even some places that they rely only on smear. They don't even perform frozens to preserve the tissue. A lot of time the tissue is very critical in neuro cases. All right, next slide. So let's just start with the cases, make it a little bit more interactive. So the first case is a 13-year-old who presented with headache and vomiting of 2-month duration. And MRI appearance T1 imaging showed this large, posterior, well circumscribed posterior fossa mass, having the appearance of a cyst with enhancing mural nodule. The enhancement is the white areas that are attached to the wall of this cyst. So this appearance, as I said, this is a very specific pattern and has a list of differential diagnoses. If you please move to the next slide. So this is the differential diagnosis of a cyst with enhancing mural nodule. You have pilocytic astrocytoma. That should be the first thing, the buzzword for it. Ependymoma can also have this appearance occasionally. Ganglion cell tumor, which is a low-grade glioneuronal tumor of the CNS, also can develop this appearance. Hemangioblastoma is not typically a tumor of pediatric age population. Usually it's an older, but also can have this appearance of cyst with enhancing mural nodule, and PXA, pleomorphic xanthoastrocytoma, and central neurocytoma. So you have this differential in mind. Let's look at the smear on the next slide. So those are the smear preparation that were done intraoperatively. And as you can see, number one, it shows you very beautifully, like highlights the background very nicely. You can see the fibrillarity, the cytoplasmic process of the neoplastic cells, and you can even see the pattern of very elongated cytoplasmic process coming out of those cells. Each cell have an ovoid nucleus. They look pretty bland, and from these cells comes this very long hair-like cytoplasmic process that we call pyloid. This is the word for this appearance, pyloid morphology. Also, you see on the right side of picture, see all these dense eosinophilic structures, and those are the Rosenthal fibers. So this combination of pyloid morphology, low-grade cytologic details, and Rosenthal fibers. Let's look at the section before making the diagnosis on the next slide. So that's the smear on the frozen, right? And I was able to tell the diagnosis from the smear, but here is a section that's gonna be also confirm this diagnosis. This is the permanent, this is not the frozen section. This is the permanent slide, and on the left image, you see this biphasic growth, areas that are slightly hypercellular and areas that are less cellular with myxoidish background. That is a characteristic low power view of this entity. And on the right side, you see the Rosenthal fibers, the spindle or oval shape of the nuclei, low-grade features. I'm not noticing any mitosis, no necrosis, no microvascular proliferation on this particular slide. So I think I have stains for GFAP. There is more. One area on the same tumor, you can see areas of vascular hyperplasia and vascular proliferation. Pilocytic astrocytomas are characterized by being vascular lesions. They can bleed, they can undergo hemorrhage, and you can see reactive vascular proliferation. You should not use this as a high-grade feature. This vascular profiles that you see on the left side of the image is not used as a high-grade feature for pilocytic astrocytoma. It's allowed to see vascular proliferation. Why? Because these lesions can bleed, and the bleeding can induce reactive vascular changes and vascular hyperplasia. So that's not an equivalent to the microvascular proliferation you see in the high-grade gliomas, for example. The high-grade features, if you see them, you have to use the mitosis and necrosis. Those are going to be the concerning feature in a pilocytic. Other than that, the majority of them will have a little bit of vascular hyperplasia, and that shouldn't be used as high-grade again. Next, for the immunohistochemistry stains. So the diagnosis, you have the Glial fibrillary acidic protein. GFAP will highlight the fibrillarity and very strongly highlighting all tumor cells, and will also show the pyloid hair-like morphology of in the background of the glial processes. Ki67 is very low, almost less than 1%. So that confirms that this case is low grade, and I know the diagnosis is pilocytic astrocytoma. WHO grade 1. And we sent for molecular testing for KIAA 1549 BRAF fusion, and that came back positive. So next slide is a quick review for pilocytic astrocytoma. It's tumors of children and young adults, commonly arising in the posterior fossa, but can also be present in spinal cord or optic nerve. Very rare in frontal or in the cerebral hemispheres, but could happen, but extremely rare. They are characterized radiologically by this well-circumscribed appearance with cyst with enhancing nodule, and these tumors are WHO grade 1 tumors. High-grade transformation has been reported, however, it's extremely rare, and a big proportion of pilocytic astrocytomas tend to have BRAF mutations, either fusion, like this one. This is the most common for pilocytic astrocytoma, but you can also see BRAF mutation like V600E, the same mutation you see in melanomas and so on. By high-grade transformation, as I said, you need mitosis and you need to see necrosis. For the next slide. So since we're talking about pilocytic astrocytoma, there is a subtype of pilocytic astrocytoma that's worth mentioning by itself because it has very characteristic features, separate and different from your typical pilocytic ones. It's called a pilomyxoid astrocytoma. The characteristic location is in the optic chiasm hypothalamic area. And typically those are solid, appear solid on imaging, don't have the cyst with enhancing mural nodule appearance. They arise in very young age group, first 2 years of life. By histology, from the name, you can see pyloid areas, but on top of that, you see prominent angiocentric arrangement. You see tumor cells tend to cluster around blood vessels, and there is a very prominent myxoid background. And you have to have these two in order to make this pilomyxoid. Sometimes you can see focal perivascular arrangement in a typical classic pilocytic astrocytoma. That doesn't qualify. Also, the clinical and radiologic is very important. The location in the hypothalamus and very young age at presentation also is concerning for pilomyxoid astrocytoma. Those typically don't have the Rosenthal fibers or the dense round eosinophilic granular bodies that are typically associated with pilocytic. The reason behind that is that Rosenthal fibers and those dense eosinophilic granular bodies that you see in pilocytic, those are not specific for pilocytic astrocytoma. These are typically occurred as a reactive process in glial cells, secondary to a slow-growing lesion. So any slow-growing tumor that's been there for a while, even if it's like a cyst or something in the brain, like a pineal cyst or something like that, will induce this reaction in the glial cells around the cyst and can give you the Rosenthal fibers appearance. So since this is a tumor of young childhood and it's more rapidly growing with more aggressive behavior than the typical pilocytic astrocytoma, they don't have time to develop Rosenthal fibers. But anyway, next point. They are also can be associated with BRAF. So as I mentioned, most pilocytic astrocytomas are having mutations and gene alterations associated with the MAPK pathways. And the most frequent one is the fusion that was present in our case, the KIAA 1549 BRAF fusion or duplication. Those are usually in the classic presentation of pilocytic astrocytoma when you have a cerebellar or posterior fossa mass. And those are relatively specific. This kind of fusion is relatively specific for pilocytic. The other BRAF fusions, like the BRAF point mutation, is typically is less common, and it's not that specific. You can see them in a lot of tumors, including some other gliomas and glioneuronal tumors. And F1 mutation may occur in association with neurofibromatosis. You tend to have this optic nerve pilocytic tumor that That's called optic glioma. It is a pilocytic astrocytoma arising in the optic nerve in the setting of neurofibromatosis 1. And rarely you can have FGFR alterations. Typically not in midline location in the brainstem. All right, go ahead. So high-grade or anaplastic features of pilocytic astrocytoma, rare, not that common, usually in older patients, and you need the 2 features. You need increased mitotic activity with or without necrosis. And the necrosis will be the pseudopalisading type necrosis you see in the upper picture that is usually associated with grade 4 tumors. May present initially as high grade, like anaplastic astrocytoma from the beginning, high grade anaplastic, or can be a low grade. And this area is debatable, and unless you have, and then also added to the debate of this entity is the newly described entity of high grade glioma with pyloid morphology. And you're not going to be able to make anaplastic pilocytic astrocytoma diagnosis without molecular or even high-grade glioma with pyloid morphology. You really have to have the characteristic molecular alterations to get there. Because you're going to get a section like this or a case like this, and in an adult, you will be tempted to call it, oh, you see pseudopalisading necrosis, you see increased mitotic activity, you're going to call it GBM, glioblastoma. So without a molecular, that highlights the importance and the challenges also at the same time of practicing neuropathology nowadays. Without a full molecular profile in a lot of cases, a lot of times you're not going to be able to reach a definitive diagnosis. And your diagnosis sometimes will have to initially be using the high-grade glioma pending molecular and waiting for the molecular classification to classify your tumor. All right, that's the first case. Can now move on to case 2. So we have a 3-year-old with a posterior fossa mass. Any questions, first of all, about the pilocytic? I'd be happy to answer. All right, let's move on. You can always type the questions as we go, and I will read them later on. So a 3-year-old with a posterior fossa fourth ventricle mass, MRI showing sharply demarcated mass in the fourth ventricle with contrast enhancement. You can see that solid mass here. Let's look at the smear preparation. Before doing that, let's review the differential diagnosis of the fourth ventricle posterior fossa tumors. We talked about pilocytic astrocytoma. That's one of them. Ependymoma, that should be the second on your list, and subependymoma, it's relative. If it's a younger age and that's an aggressive looking tumor, then medulloblastoma. The fourth ventricle has the choroid plexus, so choroid plexus tumor also can be present there. And then this rare subtype of tumor called rosette-forming glioneuronal tumor. This is a low-grade glioneuronal tumor that can arise from the fourth ventricle. That's a smear preparation. Excuse the quality, a little bit air-dried and swollen. But you can see 2 things, the nuclei and the background. I always focus at the background first. Look at does it have a fibrillary background? Because that's gonna make me make me think of a glial neoplasm. And this one, yes, it does have the fibrillarity in the background to suggest a glial or at least modified glial tumor like this one. The nuclei are oval and round, and they don't have the very long pyloid morphology we see with the other cases. It's fibrillary, but not as fibrillary like the pilocytic astrocytoma case. So you look at this and you say, okay, this looks like a glial neoplasm of some sort. The monotony and round shape of the nuclei and can guide you into thinking of possibility of ependymoma, but you're not going to be sure just by the smear. I do the next slide. Here you can see what is consistent with what we see on the image. The image is a little bit pale, but you can see the type of cells. First of all, at the right side of right corner of the image, you can see the ependymal lining. So this tumor is arising in relation to the ventricle. And the tumor itself is made of these nests and aggregates of monomorphic, monotonous, oval-shaped, round to oval-shaped cells embedded in a fibrillar background, and they have arrangement around the vascular spaces. And you click more because there is another image that's going to pop up. Yes, here is more high-power view showing this kind of perivascular arrangement. And you can see the distinct distribution of these neoplastic tumor cells in relation to the blood vessels. They are surrounding the blood vessels, sending the cytoplasmic process to the vessel wall, creating this appearance of perivascular pseudo-rosette. And you can see several of them in this picture. So this appearance is very characteristic. So we have a glial neoplasm, monomorphic, monotonous nuclei with the perivascular distribution and perivascular pseudo-rosette appearance. And next slide shows the stains. More pictures of the same thing, but better view. You can see how they are sending the cytoplasmic process to the vessel wall, creating a very beautiful pseudo-rosette in this picture right here. Occasionally, the tumor has areas of nuclear pleomorphism, but no increased mitotic activity. You can see some of the nuclei have this atypia that is slightly concerning, but in the setting of ependymoma, this is an ependymoma. I'm not going to make guesses, but in the setting of ependymoma, you can see those sometimes. You can see a slight nuclear pleomorphism, and you can also see necrosis. And both of these do not make this ependymoma a high grade. So necrosis is common, and it's not used as a high-grade feature in ependymoma. And pleomorphism can happen in long-standing lesions, similar to the ancient changes or degenerative type of atypia that you can see in long-standing tumors in general. All right, next slide, please. GFAP is very helpful. It should highlight all tumor cells and be diffusely positive. It also will highlight the perivascular arrangement and perivascular pseudo-rosette appearance. And that will confirm the diagnosis of posterior fossa ependymoma, CNS WHO grade 2. Ependymomas are grade 2 tumors, except certain subtypes of ependymoma that I'm going to discuss. That can be grade 1, but that's even questionable. Now, the classification of ependymoma, also I'm going to touch on that on the slide right here. So ependymal tumors are represent approximately 8% of all pediatric neuroepithelial tumors. And they are classified by the location. There is posterior fossa ependymoma. Those are further split into group A and group B. And in order to make this distinction of group A and group B posterior fossa ependymoma, you need methylation profiling. The other type is supratentorial, arising above the tentorium in the hemispheres. Those are rare, but can occur. And those are also divided by molecular testing into ZFTA fusion 1 and the DAP fusion positive tumors. Spinal ependymoma will look exactly like the posterior fossa, but can arise and can have different or some interesting morphologic features. And they can, one trick about spinal ependymoma, they don't necessarily arise from the ependymal canal. Sometimes you can have them in an extra-axial location, and that can cause diagnostic problem. I mean, you will always think of ependymoma, it's ependymal tumor, so it should be related to the ventricle or the central canal, but not always. Ependymoma, sometimes one of the tricky things they can do is you can have an extra ventricular ependymoma. You can have an ependymoma arising in a supratentorial location, and even worse, you can have an ependymoma arising in an extra-axial location similar to schwannoma or meningioma. So it can be challenging to make the diagnosis sometimes. Myxopapillary ependymoma is a specific subtype of ependymoma, and this is the one that was always graded as a grade 1 tumor. This has changed recently, and also you have the subependymoma that is a grade 1 tumor. All right. So the posterior fossa ependymoma is the example of what we have here. Circumscribed glioma arising in the posterior fossa. They can arise from the fourth ventricle. Usually that's the most common location. And it can either be a solid mass or cyst with enhancing nodule. And you can see hemorrhage and calcifications. Those are grade 2 tumors. And the criteria to make ependymoma grade 3, you need brisk mitotic activity. It's not well defined what do they mean by brisk. There is no certain number, but or microvascular proliferation. So brisk, I kind of screen the slide, look at an area that will have more molecular, and to me, if it's more than 5, 6 per 10 high power field, that's good enough or high enough for me to be concerned about grade 3. And usually they will be associated with microvascular proliferation, like mitosis by itself. To have an area of increased mitotic activity by itself without other high-grade features such as microvascular proliferation is kind of rare. Usually they co-occur together. All right, next. So that's the posterior fossa. To divide some imaging showing like what we have here, the perivascular rosettes or pseudo-rosettes we have. The ependymal rosettes or true ependymal rosettes is instead of the cells rosetting around the blood vessels, they rosette around the central canal, similar to the rosettes you see in neuroblastoma or medulloblastoma. But this is called ependymal canal or ependymal rosettes. Those are very rare. I mean, you will be very lucky if you find an ependymoma with ependymal rosettes. Perivascular pseudo-rosettes are almost always present, but the true ependymal rosettes are kind of rare to find. And you'll have to search for them, and oftentimes you don't even see them. Next. GFAP tend to be positive, having this fibrillary background, and EMA can have this characteristic dot-like staining in those tumors. All right, next. For the posterior fossa ependymoma, as I mentioned, without methylation profiling, DNA methylation profiling, it will be hard to tell the difference between posterior fossa A and posterior fossa V. And if it's not feasible or available to perform these, you can call it posterior fossa ependymoma NOS. Certain clinical features, PFA tend to be more common in children and PFB is more in adults. PFA has slightly worse prognosis than PFB. One of the immunohistochemistry against the K27ME3 can be used if you have it, or if not, you can send out. And if it's loss of staining or loss of immunoreactivity, that is a surrogate marker for PFA, posterior fossa type A ependymoma. So you can use this marker if you want to give them the answer of is it PFA or PFB. Okay. Grade 3, as I said, you need brisk mitotic activity and microvascular proliferation, as you see on the right side of the image. And brisk mitosis, this field has brisk bites. You can see 1, 2, 3, 4, 5, 6 mitosis in one field. That's high, very high to be enough to call it high grade or grade 3. Necrosis, again, is not a feature and does not affect grading in ependymoma. Certain subtypes or some subtypes that are quickly worth mentioning is the myxopapillary ependymoma. Those typically arise in the distal part of the spinal cord in the conus medullaris final phylum terminal location. This is the characteristic location for them. But they can be multifocal and they can even occur outside the CNS, similar to the spinal type ependymoma. They can arise also in outside the CNS and make the diagnosis challenging. You're not going to think about it if you have this in a soft tissue. Occur at all ages, most commonly affect adults. They have a very good prognosis, but recurrence and dissemination is possible and has been reported. So it used to be graded as a grade 1 in the old WHO classification, and the newer one, since they found that really it's not that benign, And even though it's low-grade tumors, like recurrence and dissemination doesn't happen often. And if it happens, it's not the most aggressive form of recurrence, but still, since they can disseminate and recur, they label it now as a grade 2 tumor. And those are characterized by, from the name, you have the papillary appearance, papillary architecture, and the myxoid cores. The cores will be markedly myxoid, and you have to, and you see this combination of the papillary and myxoid and ependymal type cells. Then you think of this myxopapillary ependymoma. Next, subependymoma. This one is the lowest grade ependymal tumor. It is a grade 1, and most of them are actually asymptomatic, and they are discovered or found incidentally in an autopsy, for example. They, unless if they get very big and start compressing on the ventricles, they really are very indolent tumors. And oftentimes they just don't present at all with anything. They have a sharply demarcated ventricular mass, and microscopically they have the clusters of ependymal cells with occasional microcystic areas, and are embedded in a fibrillar background. And the characteristic appearance of these clusters with empty spaces in between the clusters that looks fibrillarly is the diagnostic histologic features. All right. Let's touch briefly on the supratentorial ependymoma. Those are arising from the superior hemispheres, that's the cerebral hemispheres, frontal and parietal lobes location. Not always connected to the ventricle, so that the diagnosis can be challenging to think of ependymoma. And they have a bad prognosis, and the high-grade transformation or high-grade areas tend to be more common in this subtype of ependymoma. You can see in the lower image, it looks like a high-grade glial tumor, but you can still see the perivascular or the rosette formation, which can help you distinguish this as an ependymoma. Just a quick comparison between the two types of supratentorial ependymoma. We don't have to go through this slide, but those are the two types. And the ZFTA1 tend to have poor prognosis. And again, if you don't have molecular, you're not going to be able to even tell what type of it is. So typically you get an case like this. It looks like a high-grade glioma, have some features of ependymoma. You send it for molecular, and molecular should be able to tell you, what type of ependymoma it is. First of all, it will even confirm the diagnosis of ependymoma. Some markers, like you can do the L1 CAM, most places don't have these markers, so I wouldn't rely on it. You can, obviously, having the EMA dot-like staining and dot-like expression like we saw at the beginning can point you towards the diagnosis of ependymoma, particularly the YAP1 fusion positive ependymoma. All right, that's enough for this. So let's move to the next case. So this is a 6-year-old, have a progressive headache and obstructive hydrocephalus. You can see the large fourth ventricle mass and having this irregular heterogeneous enhancement and areas of cystic changes. So this appearance, as opposed to the previous one, it looks aggressive. You can see a tumor that is even starting to infiltrate into the cerebellar matter. It's not that well circumscribed anymore and has areas of enhancement. So that points toward we are dealing with some sort of an aggressive neoplasm this time. That's the intraoperative smear appearance. You can see highly cellular, small blue cell tumor, basically. You can see the cells the background is pink, but it does not have the fibrillarity similar to the previous cases. It's more of, patternless. It doesn't have a pattern. It looks like more the pink cytoplasmic fragments or fibrin or something, but it doesn't have fibrillar background. They are made of small blue cells without discernible cytoplasm. You barely identify much cytoplasm in these cells, and brisk mitotic activity. You can see mitosis and apoptotic bodies everywhere. Next slide. Have the histologic appearance confirming of a small blue cell neoplasm. Patternless doesn't really have any characteristic pattern other than just diffuse sheets of small blue cells that are highly mitotically active with abundant apoptotic bodies. And next image. All right. Some areas of the tumor from low power, you can see this nodular and nodule appearance. Have areas that are less cellular or appear paler, forming nodules. Keep that in mind, that sometimes is a feature in this tumor. And next. This is the high power view showing the difference in those pale areas. So they tend to have more cytoplasm, the nuclei are larger, and they tend to be even more mitotically active and anaplastic looking than the other components of small blue cell tumors. Those are called neuroglial nodules, and they can happen in this diagnosis of. Let's keep it until we see the stains. All right, before that, there's one stain. Yeah, so synaptophysin is diffusely, yes, that was it. The synaptophysin is diffusely positive in this tumor. Ki67 is highly elevated, above 50%. And GFEP can be focally positive. I don't have a picture of that, but it is focally positive, but not as strong and diffusely as synaptophysin. So now we are in the category of neuronal neoplasms or neural type neoplasm, and the morphology is consistent with the medulloblastoma. And that is the diagnosis in this case. Reticulin stain, I do it in medulloblastoma cases to highlight the nodularity. When you see this nodularity, there are some subtypes of medulloblastoma that have extensive nodularity, but those type of medulloblastoma tend to have extensive reticulin around the nodules. This one doesn't. So that's why I was pointing to this. And we're going to go through this as when I go through the different subtypes of medulloblastoma. Next slide, please. Diagnosis is a medulloblastoma. That's a very aggressive tumor, CNS WHO grade 4. And there are, by morphology, this is the classic subtype. So medulloblastoma can also be divided according to histology into classic subtype, nodular desmoplastic, or medulloblastoma with extensive nodularity, or large cell anaplastic medulloblastoma. Those are usually happens before the age of 16 years. And they arise in the cerebellum midline, and they have high tendency to spread to the CSF and to the spinal cord. And the classic appearance is what we saw. They are positive for neuronal marker, synapto and NSE. The case we had was classic appearance, just sheets of small blue cell tumor. Next slide, please. So this is the classic subtype of medulloblastoma of what we have here. We have small blue cells, sheets of patternless small blue cell, poorly differentiated embryonal cells, high mitosis, a lot of apoptotic bodies. If you're lucky, you're gonna find rosettes, but most of the times they're not there. Most of the times you're not gonna find true rosettes or homocyte rosettes characteristic of the neural medulloblastoma. And those nodules are called neurocytic nodules, and they don't have reticulin. So reticulin can be used to confirm that these are neurocytic nodules, and as opposed to the next case. Next slide, please. This is the desmoplastic nodular. So that's what you need the reticulin stain for, to determine this subtype of a medulloblastoma that has extensive nodularity, extensive reticulin staining. This one is maybe it's good to diagnose because this one has better prognosis than the other types of medulloblastoma. Okay. Large cell or anaplastic before moving there is another type of medulloblastoma called medulloblastoma with extensive nodularity. This one wouldn't have the reticulin stain positive, similar to the previous one. It wouldn't have that, but it would have these nodules that tend to have neuropil-rich areas with low proliferative index. And also this one has good prognosis compared to the other subtypes. The anaplastic or large cell medulloblastoma is an aggressive type and even more aggressive histologically and aggressive prognosis and lacks response to treatment. Those are characterized by cells that start to look more large, have high NC ratio, and large nuclei with large nucleoli. You can also see wrapping, cell wrapping, as you can see on the right side imaging. Tend to have more proliferative activity than the rest of the medulloblastomas. And it has to be the large percentage of the tumor that have this morphology in order to classify as anaplastic. Sometimes you can see focal areas like that in a medulloblastoma. If they are small and scattered here and there, it's not enough. You probably need to see more than 20–30%, if not more, of the tumor made of the large cell anaplastic in order to call it large cell anaplastic medulloblastoma. Next, the molecular subtypes. I'm not going to go there in much details, but there are 4 molecular types of medulloblastoma. The most common one is the WNT, beta-catenin. The second is sonic hedgehog, and then the group 3 and group 4. Well, for the first two, WNT and sonic hedgehog, there are certain surrogate markers that can be used. You can do beta-catenin stain. If you see nuclear translocation, then it's probably the WNT activated. For sonic hedgehog, there are also markers for sonic hedgehog that are not commercially available everywhere, but it can be done. But to make the distinction between group 3 and group 4, you need the molecular. And for medulloblastoma, St. Jude Cancer Center accept all these and take them and do the profiling to subtype the medulloblastoma, and they do that for free. So it's, if you ever come across a medulloblastoma case and you want to get molecular, you can contact St. Jude and they're going to do it for you. All right? That's it for medulloblastoma. Do I still have time to go through
Yes,
couple
sir.
more cases?
Keep on going.
All right. So case 4. Excuse me. So this is a 9-year-old with headache and vomiting, and you can identify the high-grade or ugly nature of this tumor by the imaging. First of all, it's a very large mass, having the areas of heterogeneous enhancement, so it tells you this is a high-grade lesion. Has mixed solid and cystic areas, and the mass is centered in the left basal ganglia and measured 4 centimeter, 5 centimeter almost. Right? Let's see if we can identify it on the smear. So the smears, I would say the one feature on this smear that kind of catches your eye when you're dealing with neuro cases is the cohesiveness of these tumor cells. First, it doesn't have a fibrillary background. You can see the background is even clean. That's number one, that kind of shifts you away from a glial tumor. This is not a glial tumor, right? The cohesiveness, how those cells are clustering and forming clusters like that is very unusual for any primary brain tumor, whether it's glial or non-glial. So when you see something like that, the first thing you see is metastasis on the smear preparation. But he's a kid, very unlikely without any known primary anywhere. So that would be a little bit unusual to think of metastasis. But let's keep going. Maybe you can help me with this. All right, so this tumor is made of those sheets of large pleomorphic tumor cells, round prominent nucleoli, also have areas of microcystic appearance. and also have a lot of those eosinophilic globules inside, or eosinophilic secretions. Let's look more additional H&Es. There is also another component. So it looks like this tumor has started to show some areas, some different component, as you can see on the left image to the left and the right side to the right of the image. You can see the second component that is made of large cells with clear cytoplasm, round nucleus with nucleoli, and have abundant vacuolated clear cytoplasm. See more pictures? Yeah, go back. Just better treated picture showing the exact same thing. Yes, can you? Yeah, this one. And this is the second component that have the clear cytoplasm. You can also notice the septae with lots of lymphocytes in them. Any thoughts? I would like to hear on this one, since we are. Cytokeratin is positive, so that confirms like the impression of having sheets, cohesive sheets of tumor cells, and they are actually cytokeratin positive. All right, I'm gonna give you the answers by looking at the stains. So the more stains we do, the more we can figure it out. So AFP start to be positive, having area, especially in both components, but it was more prominent in the kind of sheets with the cohesive clusters component. And CD117 is positive in the clear cell component.
Is it a germ cell tumor?
Yes, that is a germ cell tumor, a mixed germ cell tumor. Next slide, please. Show your things. D240 and PLAB are also positive in the clear cell component. So this is a mixed germ cell tumor. And that's a tumor you should always think about whenever you're dealing with a tumor. They have the characteristic location is in the pineal region, but they can really occur like this particular case, and that's the challenging part in this particular case. They can arise next to it. They can arise in the basal ganglia sometimes, and they can be pure germ cell germinoma, or they can be a mixture of other components. So primary CNS germ cell tumors, they are rare, but they are well described, and you have to think about it whenever you're dealing with situation of tumor that kind of look like a metastasis or looks like a seminoma, basically. The predominant component of this particular case was yolk sac. 70% of the tumor was made of yolk sac tumors, and other components that were available were germinoma. That is the seminoma equivalent in the brain, or embryonal carcinoma was 5% in this particular tumor. So germ cell tumors of the CNS, they look exactly like the germ cell tumors you see elsewhere in the ovary or the testicle, including all different types: germinoma, teratoma, yolk sac, embryonal, and even choriocarcinoma. They are most frequently arising in the pineal region, pineal gland, and that should be your clue. Whenever you hear a pineal region, first thing you should think about is it a germ cell tumor? Before, rule it out. And the suprasellar area also is another common location. There are examples like our case can arise in the thalamus and the basal ganglia region. They are usually solid and contrast enhancing, except teratoma can have cystic component. When it's pure germinoma, they are more common in males. They tend to be more common in males, in children and young adults, like 10, 15 years old. And the prognosis is when it's pure germinoma, they tend to have better prognosis because germinomas, like seminomas in the testis, are radiosensitive. The other components, like our case, they tend to behave in a more aggressive fashion. All right, move on to case number 5. I'm gonna be quick from now on, so catch the time. So this is a 2-year-old presenting to the emergency department with 3-week history of behavioral changes. And because of the rapid presentation, he presented to the emergency department. There was no time to even perform MRI. They took him to an urgent or emergent surgery to relieve the compression of this large, obviously rapidly growing mass. CT scan was only done, showing a large supratentorial mass having areas of calcification in the right frontal temporoparietal region. Let's look at the smears. So the smears have sheets of malignant looking cells, and most of the cells have the small blue cell morphology, but there looks like there is a second component that you can easily identify that are those cells with the abundant eosinophilic cytoplasm and nucleus pushed to one side, giving or imparting rhabdoid morphology. So aggressive tumor, 2-year-old, small blue cell, kind of an embryonal type neoplasm with areas of large rhabdoid looking cells. Next slide. We'll show you the same thing, but you can see even the smear was better. And this one case actually shows you how smears are actually much more superior. This is the sections on the frozen, and not the greatest. Right? You can barely see the rhabdoid cells. They're still there. You can see the large cells, but the morphology was much better on the smear preparation. Next slide, please. And the tumor has a lot of necrosis, and the left side image showing the small blue cell, and the second component that is focused on the right side image right here, showing those cells with abundant pink cytoplasm and almost and the rhabdoid morphology. Staining wise, this tumor was focally positive for synapto and very scant tumor cells that were positive for GFAP. So I have a mixture of both neuronal and glial appearance. The diagnostic stain in this case will be the SMARCB1, INI1. So you can see here the INI is lost in this tumor. And you can see the internal control of the normal blood vessels and endothelial cells still retaining the INI1, but the tumor is completely lost in INI1. And that is the diagnostic stain of this entity of atypical teratoid rhabdoid tumor. It's one of the family of SMARCB1 or INI1 tumors that have mutations and loss in the SMARCB1. Those are very aggressive tumors. They are one of the most aggressive tumors in the CNS and has to be ruled out every time you're dealing with malignant tumor in the pediatric, especially in a very young age, because these tend to present in less than 2 years of age. Even a medulloblastoma, before calling a tumor a medulloblastoma, I have to rule this one out by doing the INI1 stain. Because the morphology and ATRT tumor, even though it have the teratoid, rhabdoid, and areas that looks like rhabdoid cells like we saw, they are not always present. And the tumor morphology can be very variable. And they can have areas that looks positive for synaptophysin. You can have areas that looks positive for GFAP. So because of this variable morphology and variable morphologic appearance, doing the stains is essential in almost any high-grade tumor that you see in a young age population. All right. You can see areas of mesenchymal differentiation and areas of myxoid matrix and fibrosarcoma. This is just to highlight how they can have variable morphologic appearance, even look like what looks like a sarcoma on the right side image. Again, highlighting the importance of performing the stain all the time. If you have the rhabdoid cells and they are present, they can be positive for EMA and SMA. And GFAP and neuroendocrine markers, as I said, can be very variable, but you have to have the INI loss to make this diagnosis. All right, last case. I don't know if you have time for this one. It will be very quick, just to finish the case. So this is a 17-year-old presenting with a new onset seizure. And you can see the right temporal lobe has solid tumor with partial enhancement arising in relation to the lateral ventricle. Next. So this tumor has sheets of more monomorphic type cells. Some of them have areas of papillary arrangement. And I'm showing you this case just to highlight the importance of molecular. I mean, I already mentioned that molecular is essential, but to be honest, I see a case like this, and my differential is broad. It has monotonous appearance. Some areas looks like clearing and clear cell, like perinuclear clearing. Some areas have this papillary appearance and around the vascular or fibrovascular cores. I do my stains or maybe that will help me highlighting the tumor. So let's see. I will think of ependymoma, of course, and I will think about neurocytoma. And so I did OLIC2 diffusely strongly positive. OLIC2 used to be thought to be a glial marker, but it's not pure glial. It stains a lot of those neuroglial tumors. GFAP was focally positive in some of the cells, so that rules out ependymoma. Ependymoma tend to be more GFAP positive. Synaptophysin, however, was also positive in more cells than GFAP. So I was like, this is probably one of those neuroglial tumors that I need molecular profiling and molecular testing. And I did send for molecular, and they came back for this specific mutation, SLC44A1, PRKCA fusion. And this mutation is associated with this entity of papillary glioneuronal tumor. Of course, I mean, you can identify the papillary areas, but they are better. You're probably going to be better assessing them and better seeing them in retrospect. You know, when you're dealing with the tumor, you'll see those areas, are this even true papillary or no. The bottom line is you can think of this entity, but you're not going to be able to make the diagnosis without having the mutation and sending it for molecular profiling in order to identify the characteristic mutation. Especially that this is a rare tumor, unless if you've seen a lot and a lot and a lot of them and you know how they look like. But to be honest, in general practice and everyday practice, sometimes you're going to come across cases like that you will end up. I signed this one as a low-grade glioneuronal tumor, pending molecular classification. And the diffuse expression of OLIC2 is what made me think of along the lines of glioneuronal tumors, as opposed to ependymoma, for example. Ependymoma are not OLIC2 positive. All right, those tumors are low grade and tend to have excellent prognosis. And I think that's it. So I will open the discussion for for questions. Sorry, we talked a lot.
Can I ask one question, Dr. Osama?
Absolutely, Dr. Chata, go ahead.
Mixed papillary ependymoma. I used to see them a lot in pediatric population. As a dimple in the skin. Can you hear me, or I should raise my voice?
No, I hear you perfectly, Dr. Chata.
And I say mixed papillary ependymoma. Then I say, or ependymal wrist. And they say this lesion sometimes have tendency of metastasis. And I kid you not, I received 5 phone calls after I put the disclaimer. But there's articles about possible metastasis of mixed papillary ependymoma. How do you feel about this?
Well, I think that's the reason why they moved it from grade 1 to grade 2, because they noticed and they found that a lot of these tumors can disseminate inside the CNS, and they can recur frequently, and really the morphology does not determine the grading. So that's why they moved it from grade 1 into the grade 2 category of ependymoma. And also one thing about this myxopapillary ependymoma, sometimes they can arise primarily in an extra ventricular outside, and then like in another location altogether. Like that could be the primary. I don't know about your particular case, but sometimes ependymomas can arise in an extra CNS, outside the CNS, which can be very diagnostically challenging. to begin with. And once you make the diagnosis, like you said, you're going to receive lots of phone calls. Are you sure this is an ependymoma? The patient doesn't have any CNS tumors. There is nothing in the spinal cord. MRI looks clean. But they can happen. It can happen. And I'm glad, you confirmed that, because I've seen it a few times and I experienced it a few times myself. Not with the myxopapillary, but with some other types of ependymoma. And that's the challenging nature of this tumor.
Thank you, Dr. Elkadi. It's a beautiful presentation. And I have no further question.
Go ahead. No further questions? Oh, okay. Thank you. Anyone else?
Anyone? Dr. Reyes said, thank you so much. Excellent lecture.
Thank you.
And Muhammad Amgad has a question. He raised his hand. Go ahead, Muhammad.
Go ahead.
Yeah, thank you for really informative presentation. I mean, it's more of a really weird case we had that I once presented on tumor board. It was on Gyn tumor board, actually. And it was a teratoma that had a medulloblastoma arise within it. It was in the ovary, and they even, like, when I saw how the neuropath folks worked this case up, they subtyped it. Like, they did a reticulin, they did the whole, and surprisingly, when it was presented on tumor board, the gyn oncs wanted to treat it more like a medulloblastoma, like the CNS protocols. I don't know, it was really, really weird. I wonder if you've had anything as weird as this come up in your practice, and especially with how weird teratomas can get.
Right. No, this is a very weird scenario. I know it's basically an immature teratoma that has prominence of the neuro primitive or embryonal elements, right? And the prominence, maybe it was too much that they called it medulloblastoma, the neuro people. I have never seen anything like that. But treating it like a medulloblastoma seems odd to me. I mean, obviously, I'm not the oncologist, but I would think it would be treated immature teratoma.
Yeah, but it had like a full medulloblastoma, like full morphology and staining, and they even subtyped it as like the classic subtype, like they did the reticulin to look for.
Interesting.
I found it really weird. I thought just to share this. Yeah.
What I had a weird experience with teratoma and neuro is I had a case of teratoma with a large portion of mature brain tissue that has encephalitis, and surprisingly enough, the patient actually had psychotic symptoms. And once they did the teratoma resection, they said the patient has improved. The psychotic symptoms has improved. So apparently there is an entity called NDMA encephalitis that can involve teratoma, in the brain tissue in a teratoma, and can present with encephalitis symptoms, including psychosis, weird psychologic or neurologic manifestations. And once the teratoma is removed, the psychotic symptoms improve. That was also interesting.
Yeah, it's really weird. I remember actually they presented a case of this anti-MDMA, and we have like a monthly Chicago, all the Chicago programs do like weird case presentations. And I remember one of the programs presented a case of anti-MDMA from an ovarian teratoma. Yeah, really, really weird.
Very weird. Yeah, teratomas can do weird things.
Well, Dr. Elkadi, I have a quick question. As far as frozen sections and smears, I work mostly on adults. So we see frozen sections primarily on non-pediatric patients. And you mentioned something about enhancing lesions, something that sometimes we're privy with. We rush to the frozen section room and we don't have time to look at it, and then we look at the frozen right away and the smears, and we tell them we have a low-grade lesion. And you mentioned that they get pissed.
Yes. That's the experience I had several times until I learned, do not interpret the frozen without correlating with the imaging at first. Because when they see the radiology appearance of an enhancing lesion, they know it is a high grade, and they know they're dealing with a high grade tumor. They send frozen just for confirmation, possibly. So when they send you something, actually they send frozen more because it guides their surgery, especially if you're dealing with a young surgeon. They are not sure, am I inside the tumor? Should I resect it? Did I resect enough? Did I go deep enough to plan my resection? So they get you the biopsy, and they want to see if it is the high-grade part of the tumor or not. And oftentimes they're not successful, and they get you a piece from the edge of the tumor, which will look like a tumor. It just wouldn't have the high-grade features of a glioblastoma. So I have the infiltrate at the infiltrating edge of the tumor. You will see neoplastic-looking astrocytes sample that is slightly hypercellular, but you're not going to be able to call it high grade on frozen because you don't see any of the high grade features, right? So you tell them that this looks like a low grade, and they get really annoyed, like that's not true. So what I do in those situations is I tell them, we have hypercellular brain tissue, I don't see high grade features, and ask him, actually, can you get me a piece of the central part of the tumor? And usually this second piece that he gets me is the one that has the high-grade appearance.
Excellent. One question by Dr. Al-Ashash. He said, do molecular findings ever trump morphology in establishing the final diagnosis?
I would say all the time. I would say, unfortunately, yes. It always trumps the morphology. So I have something that looks like ependymoma, for example. And keep in mind that glioblastoma, the old name glioblastoma multiforme, glioblastoma can look like almost anything. So it can have areas of ependymal appearance. So by morphology, you have a tumor that looks like ependymoma and looks high grade. You're going to make the diagnosis of high grade ependymoma. Before doing that, it's a good idea to do molecular profiling and molecular testing in order to confirm this diagnosis. If it came back as a glioblastoma, then you just call it a glioblastoma and save yourself the hassle of several phone calls. Several situations like the last case I presented, I was not going to be able to make, I can have morphology, I have to be honest. Some tumors are very rare in the CNS, and you're not going to see a lot of them as in your practice, unless if you work in an area that has, hundreds and hundreds of these rare entities. So even by morphology, you're not going to be able to reach a diagnosis accurately or with a certain degree of accuracy, and you need molecular. It is unfortunate the way it's going, but that's the way medicine is going and pathology is going in a lot of areas nowadays. You have to have molecular classification.
Do you have in-house molecular testing, or you send it out?
I send them out. No, I have to send them out. We don't have an in-house, similar to a lot of struggling places in this country.
Well,
so yeah, I think molecular is important, and the WHO classification encourages it. Like, you're not going to be able to make a definitive diagnosis without the confirmatory molecular results.
Well, thank you so much. I agree with the final comment that Dr. Jailan Osman, she said that, thank you for an excellent lecture. You made a very complex topic very easy to understand. Thank you so much.
Oh, thanks. Dr. Kashash also having a comment. He's
good.
asking, are there situations where morphologic remain the ultimate diagnostic reference? Let me see. It's an interesting question, but maybe myxopapillary ependymoma? Since we showed a case like that, just show the slide like that, having a tumor with classic myxopapillary appearance in the classic location in the phylum, yeah, I probably can make the diagnosis of myxopapillary ependymoma without molecular. Most of the Meningiomas, of course, I can make the diagnosis without molecular, even though they even recommend doing that to grading. But I don't. But I don't. I rely on the morphology. Yeah, there are certain situations in the CNS where morphologic features remain the ultimate diagnostic reference.
Okay, excellent. Till next time. Thank you again, Dr. Elkadi. Excellent
Okay,
lecture.
thank you so much.
Very much
you so much.
appreciated.
I appreciate it.
See you guys next time. And I believe before we meet, it's going to be Eid al-Iftar. كل سنة وانتم طيبين.
So,
Take care, everybody. Bye-bye.
thank you.